Hi, my name is Manuel Loja. I am presentation to topic. My first topic is immunotherapy in renal cell carcinoma. Definition: immunotherapy is the use of drugs to boost a person's immune system so that it recognizes and kills cancer cells more effectively. Several types of immunotherapy can be used to treat kidney cancer.
I think when we look at the treatment for advanced renal cell carcinoma, it certainly has changed significantly. In past several years, renal cell carcinoma doesn't respond to traditional cytotoxic chemotherapy, and we had the advent of the first target therapies with the VEGF TKIs, over now, I guess, close to 15 years ago, that really showed an improvement in progression-free survival. And then for a while, that was the mainstay. And then, back in 2017, we saw the first data showing that immunotherapy has a role in the frontline treatment, with the presentation of that for Nivo and Ipi showing improvement in overall survival and immune poor risk versus sunitinib. And then since then, we've had other VEGF IO combinations with both axitinib pembrolizumab and axitinib adalimumab approved by regulatory agencies, given, in the case of axi-pembro, improvement in overall survival and progression-free survival, versus sunitinib in all patients in the risk group, and with axi-adalimumab improvement in progression-free survival. And so, there's a wide variety of options to offer our patients now. With, I think, TKI monotherapy being used less and less, given this data, and both Nivo Ipi, Axi Pembro really becoming a new standards of care, given the overall survival benefit of patients with renal cell carcinoma.
So the things are clearly evolving for several years now, but especially since last ESMO, where we had the results of nivolumab versus everolimus randomized phase 3 study, which demonstrated that in patients who fail one or two VEGF-targeted therapy, there is a role for IO, immuno-oncology, and namely nivolumab. It is important because this is changing one of our standard of care, and since last year, this has been implemented in all the guidelines. What is important at this ESMO is that we're starting to have more information on which will be the next step in terms of combining those agents, for instance.
Application in medicine. An important characteristic of the immune system is its ability to prevent it from attacking normal cells in the body. To do this, in the use checkpoints, which are proteins on immune cells that need to be activated or deactivated to initiate an immune response. Sometimes kidney cancer cells use this checkpoint to avoid being attacked by the immune system. Still, these round target checkpoint proteins helping to restore the immune response against cancer cells.
I think it's a truly exciting time. I mean, bladder cancer has been pretty much neglected for decades. We only had cytotoxic chemotherapy that had some modest efficacy, I would say, in patients, and now we are witnessing a true revolution with the approval of 5 immunotherapies. We are still, I think, working our way through in how to best identify patients who may benefit from these therapies and how to improve these therapies. But I think we are witnessing very durable responses in a subset of patients who can benefit from these therapies for years with really sometimes minimal side effects. I think this is truly gratifying for any medical oncologist. So kidney cancer has always been kind of like a immune responsive tumor. It's really the only other cancer where we have essentially old-fashioned immunotherapy a la high-dose interleukin-2, similar to what we use in melanoma, approved with long-term benefits. So since November 2015, we have nivolumab approved, a PD-1 inhibitor, and we do know that we can induce very durable responses in a small subset of patients, around 21% of patients. However, simply speaking, it's not enough. And I think the future is going to be to look at combination therapies. This will come forward in the short term, I would say, in two different flavors. One is the combination with VEGF inhibitors, and the other one in combination with another immune checkpoint inhibitor called CTLA-4 inhibitor, or Yervoy. And I think we will witness in a very short amount of time how the first-line therapy for kidney cancer is going to be transformed. It's going to be driven by immunotherapy, truly.
Pros and cons. More serious side effects occurs less often, although they may occur. These drugs take the brakes of the body immune systems. Sometimes the immune system begins to attack other parts of the body, which can cause serious problems with the lungs, intestine, liver, hormones producing glands, such as the thyroid, kidneys, or other organs. In some people, the serious side effects can be life threatening.
The combination in immunotherapy are focused on the first line, and clearly it's the future. It's already the standard treatment with double IO TKI. But the main point, we have two challenges. First, we have to know how to select the good combination for the good treatment for the good patient. And we have IO or IO TKI, and we don't really know. We need biomarkers to identify a patient who will derive any benefit from this combination. And in order to identify this kind of biomarker, we launched in France a randomized phase 2 trial called Bionic, and we select patients based on molecular groups defined on frozen tumor samples. And based on these molecular groups, we allocated treatment double IO nivolumab ipilimumab or nivolumab alone or TKI alone. And with this kind of approach, I think we are going to find some biomarkers of response, and the trial is closed, the inclusion of the trial are closed, and so we plan to show the first result, I think, at the end of the year at the ESMO Congress, and we will see if we can try to find the good biomarkers to respond to this treatment, because we have a challenge on toxicity concern, of course, and we need this kind of biomarker-driven trial.
Apply in Ecuador. ISO apply in Ecuador. In Ecuador, these drugs are widely used by doctors to improve the stability of the patient who has kidney disease. In many cases, they are used immediately after a good evolution of the patient.
So it really, as I was mentioning, has been transformative for the care of patients with advanced RCC, and it's not sort of a new therapy either. We think of immunotherapy in kidney cancer, and it's not that long ago that it was the cytokine era, things like interferon and high-dose IL-2, and then in the mid-2000s, the introduction of anti-angiogenics or blood vessel blocking agents really transformed the management of kidney cancer at that time, and patients were living longer. And what we've seen more recently is with the introduction of immune checkpoint blockade, not just by itself, but often in combination with other drugs, has really led to dramatic responses in a number of patients. I think what's most exciting is it's not only that more patients are responding and more patients are living longer, that's tremendously important, but that we're seeing, hopefully starting to see at least a tail of the curve, meaning that some of these patients really do seem like they have long-term or durable responses. And so the hope is not just to get better and better treatments, but actually to try to get to a point where we're having a lot more long-term survivors with kidney cancer. And the ultimate goal is cure and getting towards that goal for more and more people.
Conclusion. Side effects are often serious and can rarely be fatal. Only doctors who have experience with the use of this drug should administer this treatment. My second topic is Ribavirin for chronic hepatitis E virus infection in transplant recipient. Definition: hepatitis E virus (HEV) infection is the cause of epidemic acute hepatitis in developing countries and sporadic acute hepatitis in industrialized countries.
Hepatitis E is RNA virus, spread by the fecal-oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged viremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank you for watching. For
Ribavirin for chronic hepatitis. Ribavirin is a nucleoside analog which has a broad spectrum of antivirus activity. It inhibits the replication of RNA in cell culture. It decreases hepatitis C activity. Monotherapy. A meta-analysis of 11 trials has demonstrated that ribavirin as a monotherapy has no significant effect on achieving a virological response. Hepatitis C. Hepatitis C is an infection caused by a virus that attacks the liver and leads to inflammation. Liver transplant. The only effective treatment for people with end-stage liver disease is a liver transplant. Ribavirin used after transplant. It comes as pill, capsule, or liquid. Ribavirin is taken twice daily and dosing is based on weight. Side effects. The major side effect of ribavirin is anemia, which is dose-dependent and can be managed by taking red blood cell growth factors by lowering the dose of ribavirin. The researchers found is vastly unreported as a cause of death, registered in only 19% of death certificates among those in the cohort who died. Finally, the conclusion of this research is that ribavirin seems without beneficial effects on serum virological response and liver-related morbidity or mortality and significantly increasing of the risk of adverse reactions.
Application in medicine. The definitive diagnosis of hepatitis E is usually based on the detection in specific IgM antibodies against this virus in the blood. A test that is usually sufficient in areas where the disease is infrequent. Rapid tests are available for use the file.
Like the majority of patients who receive the standard therapy for hepatitis C, Maurice Brown went through the notoriously brutal therapy only to see the virus come back, and until now the only backup was a second round of the same punishing treatment and even slimmer chances of being cured. Now a clinical study out of Duke University Medical Center finds adding the investigational drug Telaprevir to the standard 2-drug therapy during retreatment cures 4 times more patients.
When we gave the 3-drug regimens for 24 weeks or for 48 weeks, overall we cured just more than 50% of these people. So 4 times what we would have expected to see and what we did see compared to just retreating people with the same 2 drugs we use now.
Retreatment adding Telaprevir worked in Maurice's case. He's cured 1.5 years and counting. But the new therapy does come with costs. Although more patients were cured, some experienced a skin rash, sometimes so severe that they had to drop out of the study.
So on the one hand, we're curing more people, it's a more effective therapy, but as we say, there's no free ride, and when you add in an extra drug, there's extra side effects.
About 4 million Americans have hepatitis C. It's the most common condition leading to liver transplantation in the U.S. and can lead to cirrhosis and liver cancer if left untreated. The study findings are published in the New England Journal of Medicine. FDA approval for Telaprevir may come next year. At the Duke University Medical Center, I'm Mike Garrison.
Pros and cons. Until recently, it was believed that HIV only causes acute hepatitis and fulminant hepatitis in select cases without the possibility of becoming chronic. It is estimated that in Spain there is prevalence of 2.2 at 7.3% of antibodies in the general population. The evolution of chronic liver disease was unknown, but recent studies and the case described showed it as in our case. Most of them are immunosuppressed patients, but exceptionally it can affect immunocompetent individuals.
I'm here today with Dr. Michael Charlton with the Intermountain Medical Center, and thanks for joining me today. I understand you're giving a presentation to the postgraduate course during the International Liver Transplantation Society annual conference. Tell me a little bit about that presentation.
That's right. There's been a tremendous advance in our ability to treat hepatitis C, and it's with these medicines called direct-acting antiviral agents. And even though they're generally very safe, highly effective, they do interact with a number of medications that transplant recipients are on, and other medicines that you may be on for heart therapy, for example, and then things that you might just take over the counter. So we're going to spend some time speaking to the attending providers there about what to look out for and how to manage these drug-drug interactions.
Okay. What are the main drug-to-drug interactions that you're looking to do, and then what are the complications associated with those interactions?
Probably the most important single one is because it's important, it's dangerous. There's a drug called amiodarone, which is used to treat heart conditions. And if you give these 2 drugs together, something called sofosbuvir, one of these antiviral medicines with amiodarone, it can actually stop the heart or certainly slow it down dangerously. Another important drug-drug interaction is effective proton pump inhibitors, which are drugs to treat heartburn. Many people are on these drugs. If you give one of these antiviral medicines, which can cost $1,000 a day, one of them is barely absorbed if you take enough of these acid-reducing or proton pump inhibitor medicines. So you decrease the effectiveness and essentially can waste the drug if you take them both at the same time. So things like that.
Okay. No, I appreciate the information on that today and look forward to the other research being presented from Intermountain Medical Center at the conference.
Thank you.
Thanks.
Issue apply in Ecuador. In Ecuador, there is no specific treatment that alters the evolution of acute hepatitis E. As the disease usually remains spontaneous, it is not usually necessary to hospitalize the patient. The most important thing is to avoid unnecessary medication. Antibiotic and paracetamol should not be administered.
Our lab studies hepatitis B and E viruses, which cause about 300 million infections worldwide and kill almost 1 million people annually. Neither one has a cure. We have developed new screening systems to identify new drugs to cure these viruses. Both hepatitis B and E viruses affect the liver, but they are very different viruses. Hepatitis B virus is transmitted through the blood and other bodily fluids. It enters liver cells where it hides in the nucleus. We try to find drugs that can kill this virus without causing harm to the patient. Hepatitis E virus infects people through contaminated pork meat and water and stays within the cell body. We try to find molecules that can stop the virus from making copies of its genome. Our screening systems are faster and safer than existing platforms. Our systems are high throughput, meaning that we can screen millions of compounds within a short period of time. We modified both viruses so they are safe and robust for screening. The screening system closely mimics the situation in patients with chronic hepatitis infections. With these screens, we hope to provide cures for viruses that cause serious global health problems.
Conclusion. The ultimate goal of the strategy is to eliminate viral hepatitis as a public health problem. To this end, global targets are set to reduce new hepatitis virus infection by 90% and mortality from the disease they cause by 65% by 2030. The strategy also defines the measures to the taking by the countries and the WHO Secretariat to achieve these goals. Thank you very much.